Hi, my name is Hans Lee from MD Anderson Cancer Center in Houston, Texas, where I focus on the treatment of multiple myeloma and light chain amyloidosis. At this year's ASH 2024 meeting, the final results of the Phase 3 Andromeda study was presented by my colleague and co-investigator, Dr. Stasis Kastridis. Just as a little brief background, this was a Phase 3 randomized study evaluating the use of daratumumab, cyclophosphamide, bortezomib, and dexamethasone for 6 cycles, followed by daratumumab monotherapy every 4 weeks for a total of 24 months, versus cyclophosphamide, bortezomib, dexamethasone, otherwise known as CyBorD, for 6 cycles for newly diagnosed light chain AL amyloidosis. The initial results of the primary endpoint of the study was reported approximately 3 years ago, which did demonstrate a significant improvement of complete hematologic response rate in the Dara-CyBorD arm versus CyBorD. And this led to the regulatory approval of Dara-CyBorD for newly diagnosed light chain amyloidosis and established Dara-CyBorD as a standard of care for the treatment of newly diagnosed AL amyloidosis in this particular setting. At this year's meeting, the 5-year follow-up and the final analysis was reported. And this was important and significant because they reported on a couple key secondary endpoints, including overall survival and major organ deterioration progression-free survival, which was a composite endpoint evaluating end-stage cardiac disease, end-stage renal disease, hematologic disease progression, and overall survival. So nearly 400 patients were randomized in the study to either receive Dara-CyBorD or CyBorD with newly diagnosed AL amyloidosis. Approximately 70% of patients had cardiac involvement at baseline. Approximately 60% of patients had baseline renal involvement. And with the additional 5-year follow-up, what it did show was that there's a deepening of hematologic response rates in the Dara-CyBorD arm at about 60% versus a complete hematologic response rate of 19% in the CyBorD arm. So nearly tripling of complete hematologic response rate with the addition of Dara to the CyBorD backbone. In addition, the cardiac and renal response rates were 2 to 3-fold higher with Dara-CyBorD versus CyBorD alone with longer follow-up. And looking at some of the key secondary endpoints, including overall survival and major organ deterioration progression-free survival, with the addition of daratumumab to CyBorD, there's significant improvement of both overall survival and major organ deterioration progression-free survival with Dara-CyBorD versus CyBorD alone. And this was pretty consistent across all major pre-specified subgroup analyses. Finally, when looking at the safety profile with longer follow-up, there's really no new safety signals seen with the addition of daratumumab to the CyBorD backbone. Small increase in infection rate and grade 1 and grade 2 upper respiratory infections and pneumonia, but overall, this is a very safe and well-tolerated regimen in this particular patient population. So in summary, with the 5-year follow-up and the final analysis of Andromeda, these results really establish and reconfirm that Dara-CyBorD is the standard of care for newly diagnosed light chain amyloidosis with both an overall survival benefit and a major organ progression-free survival benefit with the use of daratumumab with CyBorD versus CyBorD alone. This was a new endpoint developed for this specific study, and so there are unique characteristics of light chain amyloidosis patients. They're different than multiple myeloma that have special considerations when considering the endpoints of progression-free survival. In particular, amyloidosis patients can have involvement of specific organs, most critically the heart and the kidneys. And so again, this composite endpoint not only looked at death and progression by hematologic response as it's a typical progression criteria, but also organ deterioration. And this also looked at cardiac or end-stage cardiac disease and end-stage renal disease. So the definition of end-stage cardiac disease for the major organ deterioration progression-free survival endpoint had 3 criteria: cardiac transplantation, the use of a left ventricular assist device, and the use of intra-aortic balloon pump, which signified end-stage cardiac disease. So the definition of end-stage renal disease for this composite endpoint was basically onset of hemodialysis or kidney transplantation. I think one of the really game-changing medicines actually for light chain amyloidosis has been anti-CD38 monoclonal antibody-based therapy with daratumumab. And there have been previous studies showing retrospective analysis looking at the use of both single-agent daratumumab and daratumumab in combination in patients with previously treated light chain amyloidosis. And so if a patient has not received daratumumab and has relapsed, certainly I think using a daratumumab-based regimen would be my go-to in this particular setting. And even if a patient has been exposed but not refractory to daratumumab, then retreatment with an anti-CD38 like daratumumab would be a very reasonable option in this context. There's been tremendous progress in the treatment of light chain amyloidosis over the last 3 to 5 years, particularly with the introduction of daratumumab to the CyBorD backbone. I think this has really been sort of a landmark, monumental sort of study for the field. Given that this was the first time there's actually a drug approved uniquely for light chain amyloidosis, which is, sort of unprecedented in the first time. And I think more progress is being made with other therapies in light chain amyloidosis. So I think the field is very promising and really excited what's moving forward with research.